I want to welcome Dr. Albrecht Stenzinger from the Institute of Pathology at University of Hospital of Heidelberg, who's going to talk to us about immuno-oncology and realizing their full potential. Welcome.
Thanks.
Thank you. Yeah.
Thanks. Yeah, thanks everybody. Thanks for having me here. Also, thanks a lot to the great audience here in the room, but also through the internet. So it's really great to be here in Amsterdam and be part of this story. I couldn't agree more with you that education will play an increasing role, communication will play an increasing role, and I think it's also very crucial, and I'll tell you in a second why this is the case, that this kind of technology stays in the hands of the people who actually do the stuff every day in the clinical setting, who talk to the patients, who talk to the oncologists, to the radiotherapists, to the surgeons to really get this going. Now, topic of today is immuno-oncology. That's a very hot topic, very emerging in a fast manner. And just to remind you, if you look back in history, it's just 150 years ago that we made up our minds and started to understand that there are tumor cells, but there are also immune cells, right? And they both intermingle. Nobody actually knew what's going on there, but it was recognized, so that's great. And then it only took 150 years until we are in a situation where we can leverage that from a clinical point of view, and I think that's amazing. It's not something that people back in the 1860s would have expected in Germany and elsewhere, and we are still there. However, as we have heard in the previous talk, there are downsides, obviously, right? So we do face the situation that with PD-1 blockers, PD-L1 blockers, a lot of patients do not respond, right? So we see great responses in, let's say, 30%, maybe 40% of patients, but the others do not respond. So they develop resistance either at baseline or during therapy. And I'll come back to that in a second. Now, why is that so complex? So why don't we, just provide PD-1, PD-L1 blockers, other immune checkpoint blockers, and problem solved? And if you have a look at that slide, you can, see how complex it's actually getting. So you have a release of cancer cell antigens that's driven by mutations. These antigens need to be selected. They need to be recognized by the immune system, and then they eventually need to be killed. And you see that there are many different players, factors that, timely influence that kind of full picture, including, I like that a lot, traditional Chinese medicine. So we'll see how that plays a role in the future. But really, so that also nicely explains why, for example, immunohistochemical approaches like PD-L1 don't tell you the full story. So that's a biomarker. It is being recognized by the FDA as primarily as a complementary diagnostic tool, meaning you can use it. It will give you some additional information on how this patient may behave in a clinical scenario when he or she gets checkpoint blockers, but it is still only complementary. And having this complex interplay in mind is very obvious in my personal view that a single biomarker is very unlikely to explain that complex interaction that's going on there. And this also ties in with the previous talk. If you think about a single patient, you can clearly see, and that's a very old concept of immunoediting that has been introduced almost 70 or 60 years ago, where, at the very beginning, the tumor is probably highly immunogenic, and then over time, with increasing accumulation of mutations, you see resistant variants emerging. And that's exactly what we now see with immuno-oncology. So a very old concept now being leveraged in a clinical scenario, and it's really kind of a proof of concept that this really holds true. So again, we are dealing with resistance mutations. We are dealing with the very same problems that we are facing in the targeted scenario as well. And that's being shown here, right? So if you look, for example, at patients with colorectal cancer, Lynch syndrome, you have a very powerful scenario in terms of checkpoint blockers. If you think about a hot microenvironment, many lymphocytes mingling around there, other inflammatory cells, high mutational load, and still, not all of these patients respond, right? And question is why. So some of these patients might just go straight down the hill, others will somehow circumvent and take another route. And the question is really why? Why is this the case? Now, I think a very clear concept that's important to realize is that mutational load varies among tumor types, right? As you can see here, tumor types that are highly exposed to carcinogens, for example, lung cancer, melanoma, if you think about UV light, they usually tend to have a very high mutational load, and there are other cancer types that do not. And with that mutational load, you also have a proxy for the immunogenicity, meaning the development of neoantigens in a given scenario. And that is a paradigm that's now being used in a clinical context. The interesting question, though, is what's driving mutational load, right? I mean, is it just something coming out of the blue? Is it only due to external events like UV light, tobacco smoking, whatsoever? I think it's not. So if you look at the slide over there, there are a lot of genetic determinants that actually cause mutational load, high mutational load, like, for example, polymerase epsilon mutations, like mutations in HRD-related genes, like mutations that eventually confer microsatellite instability. And the interesting point here, that's my second point for that slide, is if you look all the way through the patients, you still see that there are patients who do not respond, although they have a high mutational load. So look at study ID patient number 3, right? So he or she has a high mutational load. He or she should respond to some extent, but that's apparently not the case, and we need to find out why this is. I think it's fair to say that this is really a game changer. So these are famous data from Johns Hopkins, clearly showing that patients, whether they have colorectal cancer or other cancer types, when they have an MSI genotype, they tend to respond greatly towards PD-1 blockade. And in a very recent paper, they also showed that this is really not only the case in colorectal and endometrial carcinoma, but among many different solid and major tumor types. And that obviously raises the question in a clinical scenario, which patients do you actually test? Would you test all of them? Every single oncology patient for MSI? These data suggest that, but nevertheless, keep in mind that frequencies are quite low. So prevalences hover around 2%, 5%. Nevertheless, from a clinical point of view, it's absolutely stunning. And therefore, it takes no wonder that the FDA in May this year actually approved MSI high as a biomarker. And the very interesting concept here is that this is histology agnostic. And that's a true game changer. So all of you who follow the FDA decisions closely quickly realize that this is a situation that has not happened before. So that's a very broad indication for a specific drug. And the only point is it MSI high? And, you know, that could also be something that we see in the future increasingly. Just to highlight that once more, DNA repair genes might be great candidates as response predictors, right? So MSI is only, if you will, a kind of phenotype that you read out, but there are core underlying mutations like genes involved in DNA repair deficiency, like mutations in polymerase epsilon that do create high mutational load. And as you can see here on that slide, there are a couple of trials underway. So if you check, for example, in prostate cancer, metastatic castration-resistant prostate cancer with DNA repair defects, there's a great paper from the De Bono group at the Royal Marsden who showed that very strongly. And now these patients are put on Nivo, and the question is whether BRCA in its broadest sense could be used as a kind of biomarker in that scenario. So meaning that we're going to see these two themes converging over time. And as you can also see, that's also being highlighted on that slide, the type of mutation actually may play a role. MSI is hinting on that, right? So MSI has a lot of frameshift mutations and so on. So the antigenicity is certainly also related to the type of mutation, and there are at least some data suggesting that, for example, copy number gains are not that immunogenic. And I think previous or the next studies will show where this is heading to, but it's certainly very, very interesting. And the other major point here really is that we are dealing with biological themes that operate across cancer types, and that has never been seen before. So if you think about, for example, EGFR resistance mutation T790M, that is specific for lung adenocarcinoma, primary mutation, EGFR, let's say del exon 19, and then a second mutation that is T790M. Here we are talking about BRCA, for example, MSI, that's operating across. So pick a tumor you have in mind and you'll be right there. And I think that's something that, you know, changes our way we see cancer a lot, and we'll see more in the future. These are data, you know, suggesting that mutational load can be utilized, for example, in melanoma, also in non-small cell lung cancer. As you can see, and I've highlighted this here, the mutational load cutoffs are, you know, vary to some extent. This is simply due to the fact that we are not talking about a, you know, true biological underpinning, but more of clinical utility. So how do I stratify patients in a meaningful way? And in that rather small but very important study, these colleagues showed that there is a cutoff that can actually discriminate patients who respond greatly and others that do not. And here, as a further proof of concept, that's a retrospective study that was published at the AACR or presented at the AACR for the first time. So these are real study data showing that patients with a high mutational load, so these are whole exome sequencing data, cutoff was 243 for the high group, do respond very well towards Nivo, Whereas if you check the same group in the chemotherapy arm, they do not respond very well, right? That's another very important theme that we may see in the next couple of years, that one could actually use those so-called molecular markers also for conventional therapies, right? So think about BRCA and platinum response, for example, but there may be other options as well. So that's something that we certainly have to keep in mind, and here we can clearly see if you use a retrospective analysis of a true clinical trial, you can see that this has clinical utility. And here is another example of a phase 2 trial that was presented by Rosenberg and colleagues at the ASCO in 2016 on urothelial carcinoma. And there they took a slightly different approach by using panel sequencing, but still they were able to identify different groups with different mutational loads that respond towards therapy at a certain range. Now, the topic that's currently emerging, and it really refers back to the very beginning of my talk, is resistance mutations. As I told you, with the cause of disease, there is a high immunogenicity at the very beginning, and actually tumor mutational load is, a good proxy, but not an optimal biomarker. The optimal biomarker would be the one where you would just identify the 1 or 2 single neoantigens. Then you could discard the whole tumor mutational burden stuff anyway, right? But we are not there yet, so we need to understand how we could actually identify those true neoantigens in a specific single patient. And then over time, resistance mutations develop, and that's nicely summarized here. So if you see, for example, if a patient or a tumor has a loss of beta-2 microglobulin, if you see, for example, a loss of the entire antigen presentation machinery or specific genes encoding this machinery, there is a very high likelihood that this tumor will not respond to immunotherapies anymore. This has been well known for quite some time, but it's now coming back to our attention because we have the tools at hand to actually leverage that in a meaningful clinical way. And just as one example, there are many examples now out there. So PIK3CA mutations seem to confer a negative response. PTEN loss seems to play a role here. JAK1/2 mutations, beta-2M mutations play a role. EGFR mutations, for example, in lung cancer and non-small cell lung cancer, appear to be some negative predictor in terms of response towards immunotherapies, meaning that it might make sense to actually pre-stratify and deselect those patients prior to testing for TMB. And, to wrap this up somehow, how are we going to deal with that in a true diagnostic scenario? So here's my take on this, happy to share and discuss with you. I think we do need a panel that's 1 megabase plus, right? So that would mean that this is a panel that's even in size way bigger than the Oncomine comprehensive assay that has been used in the NCI match trial, with great success though. But for the approximation of tumor mutational burden, you will probably need at least 1 megabase. I would say 1.5 or even more. Also, there is a crucial point in terms of the panel composition. Which genes do you include? So I try to highlight that there are genes that actually cause mutational load. So it might make sense to actually include these, including MSI testing as well, right? So might not make sense to do 2 or 3 or even 4 tests on one single biopsy, given the point that many of these biopsies have low tumor cellularity. So that's something that we need to have in mind. And And then we need to include possibly negative predictors. So clinical utility has still to be shown in prospective clinical trials, but nevertheless, the retrospective data suggest that there is something going on there. And then from the bioinformatics point of view, if you only sequence FFPE material, you don't have the germline subtracted, you need to think about how you deal with that, right? So which mutations are truly germline, which might be somatic? That's something we have to deal with. And then obviously, deamination artifacts caused by the FFP procedure play a role. And especially at low frequency, we can see those, and it's important to actually filter them out prior to some analysis. So my summary on the very last slide is really, there are positive and negative genetic biomarkers. The hot topics are probably the determination of neoantigens with high confidence. I think we are not there yet. There are great papers out who have shown that this is feasible in principle, but I think we still need some time to actually get there in a true clinical scenario if you think about turnaround times and so on. And secondly, we definitely will see a convergence of these two biological themes operating there, mutational burden on the one hand, or the concept of immuno-oncology and the idea of leveraging DNA repair, deficiency, and other genes that play a role here. And then obviously, what plays an important role as well is the tumor microenvironment, right? So the composition of the immune cells, the abundance of the immune cells, specific T cell repertoires that play a role here. So as I said at the very beginning, there is a close interaction between these two. With that, I think I'm coming to an end and happy to take any questions. Thank you.
Thank you, Dr. Stenzinger. All right, so just a quick reminder to the audience. So you can, if you're using the app, you can submit your questions during the talk as well, and that way there's a slight delay in terms of the questions showing up as opposed to when you enter them into the app. So again, feel free to ask your questions in the app during the talk as well. So I guess we have our first question here. In terms of how can the development and understanding of these new immuno-oncology biomarkers lead us to generate new and improved therapies?
Yeah, I think that's a great point. So, as I said before, problem with the current checkpoint blockers in use is really that most patients do not benefit from it. I think that's simply fair to say, although we have seen great responses, no doubt. So I think we need to get a deeper molecular understanding of what's going on there, really. And then if you think this through in terms of resistance mechanisms, I think it's very crucial to understand these resistance mechanisms and possibly develop therapies that could, circumvent these, like, for example, T709TM in the EGFRI setting.
That's a great point. So it's an interesting one in terms of how would you go about designing an ideal gene panel that that guides immune response therapy use. And I'll broaden that question as I was looking through your slides. Question is, obviously it's just more than tumor burden or response, or you need to look at the tumor profile. You got to look at, as you said, the microenvironment and the response of the immune cells itself to all these different mutations that may or may not be carcinogenic. Now, so how does one actually think about not only the ideal gene panel, but what tests to actually provide a patient?
Yeah, that's also, I think, a very hot topic that will keep us busy over the next couple of years. I think there are three major factors that you have to weigh in there. One is certainly, the economic situation in terms of reimbursement, right? So what is reimbursed in a specific country. That's, I think, very crucial. The second part that also plays a role here is resources, right? So if you tend to use larger gene panels, so think about the S5, right? So you could possibly load, I don't know, 4 to 6 cases on these. If you think about short turnaround times, you may need more than one of these. In terms of panel design, I think there are 2 major parts. One is the size of the panel. To approximate that in a meaningful way, if you use whole exome sequencing data as a kind of benchmark setting, I think you need to have a gene panel of 1.5 megabases plus. That's number one. I think one would want to include known drivers, because with low tumor cellularity small biopsy samples, it might become a problem to actually, extract DNA, RNA multiple times. And that also gets back to the economic situation, right? The stakeholders in the healthcare system, are they willing to pay for a whole bunch of different panels? And then, obviously, we need to include negative predictors. So it may well be that, for example, a patient who has a high mutational load at baseline but would have a mutation in JAK1 plus a loss of the other allele would not respond to therapy anyway in the first place. So why would you put this patient on treatment with all the side effects and so on emerging? But it is important to say here that we need true prospective clinical trials to show clinical utility, obviously.
Got it. Got it. Are there any questions from the audience here? We have a chance to ask a question directly of the speakers. And I think Roland has a unique throw microphone there. Any questions from the audience? Right. I'm going to maybe ask you a question that was not covered. So we talked about the different types of tests, and obviously there's if you look at clinical paradigm, there's possibly a sequencing, pardon the pun, sequencing of different types of tests you can give a patient, but there also might be sequencing of different types of therapies. So you could take a look at immunotherapies versus targeted versus chemotherapies. How do you see this evolving in the light of the research that you presented today?
Yeah, I mean, I think, so currently there are roughly 1,000 trials on checkpoint blockers alone underway. We need, and we are eagerly awaiting these results at ASCO next year, AACR, ESMO, and so forth. I think immuno-oncology will play an ever-increasing role. I don't think, though, that this is going to be the holy grail at the end of the day. That's what people thought, like maybe 5 years ago. Now we have it. I think that's not the case, and the obvious resistance of many patients shows that it is great for a subpopulation of patients, and it's a big subpopulation, no doubt. But still, we need to think about what are you going to do with the other 60 to maybe 70% who do not respond. I think targeted, and that's a second point I think you're hinting at, targeted therapy is not something that's going to be replaced, right? So an ALK fusion positive non-small cell lung cancer will be always treated along these lines. And then one could see whether, if there are no other options in the pipeline anymore, whether such approaches might play a role. However, current data are suggesting that clear driver positive cancer types do actually not respond very well to these immuno-oncology approaches. But that's definitely, research underway, and we need to see how things are going.
Do you ever see a world where these therapies can be given at the same time, simultaneously?
In an ideal world, I think that would be very fascinating. I think given the unwanted side effects, it certainly hampers that kind of approach. I'm not saying that it's impossible, but that's something that we need to weigh in there very, very carefully.
Okay. Another question that's come up is how can emerging findings in immuno-oncology be incorporated into NGS panels? So how do you see that happening?
That's actually a question for you guys, right? So how do we incorporate that in a short turnaround time? Yeah, but I think that's another great point. Obviously, there are so many new research data coming out almost every week. How do you keep track?
Yeah.
And what's meaningful? So I think number one is really that one has to stick to prospective clinical trials that have shown clear clinical utility.
Yeah.
So if, for example, there will be a prospective trial for TMB positive, it might be very likely that this will be a new biomarker. Whether, for example, negative predictors, which are very interesting from an academic scenario or a point of view, will play a true clinical role in the future really depends on whether a trial is able to show that this can be used as a significant biomarker.
That's a good point. You asked me the question about what are we doing. A part of our approach has been to make the customization of the panels much, much easier and more flexible, right? And including new technologies that make it more accurate, more sensitive than it has been in the past, especially as you start looking at very, very rare events, and molecular tagging has definitely changed that space and will continue to change that space. So look forward to partnering with you and others on that. Roland, any other questions? Two more? Okay. So multiple institutions and networks are working on developing larger panels at this stage. Obviously this is a question for patients and physicians, is which panels do we standardize on and how do we compare results across these various centers?
Yeah, that's I think, again, another great question. I think, and there again, economy comes into play. I think we have, at least in Germany, faced a situation where, we didn't see full reimbursement for larger gene panels. Although they would have made sense to some extent, we couldn't do that for simple financial constraints there. That has been changed in Germany last year, and I think that was a very wise strategy. We'll see larger gene panels come in. Human mutational burden will be, if it's coming, it will be a clear game changer there, because we are really talking about big panels. How we align there and find ways to create similar panels, that's a good question. It would make sense, because that would allow to actually build up databases, for example, where you could share genetic data plus clinical data, like, for example, the Moonshot initiative by Joe Biden suggested. And I think something like this would make sense. And there it actually would make sense to have a panel that has comparability in terms of size, in terms of the genes that are being interrogated. I think, as we all know, across nations, that's certainly, a challenge. However, as you have nicely shown with the NCI match trial panel, that's definitely doable. And if you think a little bit further, many of these gene panels are actually being dictated by the therapeutic response, right? So if we take the view from there and this perspective, thinking what are the drug targets that are currently out there, I think we could find some standard across nations where we would say, along the lines of the NCI match trial panel possibly, to find a certain setup of a panel that can be used and compared across institutions.
So definitely more of a coordinated approach required there.
Yeah.
We have time for one more question, Roland. See if it comes up. Okay, so how would you relate the effect of age of the patient in terms of the efficacy of immuno-oncology therapies? This is interesting. I don't think we saw the data out there, but is there one?
Yeah, I think data are still very preliminary, so I wouldn't want to make any firm statement on that. I think, given the fact that we do see severe side effects with these patients, it really, depends on the individual constitution of the patient from a clinical point of view, whether you could give such therapy or not, and the future and the ongoing trials will tell us whether, older and, so older patients, and to which extent they actually benefit from these therapies.
Well, excellent. Well, thank you again,
Thank
Stenzinger.
you.
Yeah, a fascinating talk. Appreciate that.